Starting by arthroplasty, we dealt with the ideal total hip and the arthroscopy. We discussed the knee stability, then the pediatric webinar for DDH and the spine for sagittal balance with a lot of international speakers, and ended last week by our foot webinar on pes planus. All were very successful webinars. Now, it's my pleasure to introduce our trauma team, the top notch among our teams, the team who was organized by our great professor long ago, Professor Hassan Al-Zahir, who introduced the OO to Egypt long ago, maybe 50 years before. Now our sixth webinar of Ain Shams Orthopedic Department, dealing with a very debatable subject. Among in every item, it is very debatable, I mean. And in every step, concerning starting from timing to type of production and way of fixation. We'll speak with the femoral neck fracture in young adults, the unsolved problem. It's my pleasure also to welcome our distinguished speakers, Professor Dr. Radwan Gamal and Dr. Mustafa Al-Abd. And our strong panel today will be Professor Dr. Tariq Sami, Professor Dr. Wael Samir, and Professor Dr. Ayman Abdelaziz. And this special night will be moderated by very special moderator, Professor Zahir Hassan Zahir, the trauma team leader and the AO coach. Again, thanks to Elixir, our partners for success. And lastly, it's my pleasure and our honor to have with us Professor Ibn Carroll, the professor of orthopedic from USA, the director of trauma and fellowship Wake Forest Health Sciences, North Carolina, to share with us his experience with such wicked fractures. And now I will hand the mic to our maestro and the moderator of this night, Professor Zahir Hassan Zahir, wishing you a fruitful night and wishing him good luck. Father, Dr. Zahir.
Good evening, everyone, and I'm happy that you are joining us in this sixth webinar, which is a trauma webinar. And thank you, Dr. Amr, for the introduction. And I am I'm the moderator of this session, of this trauma night. And I am very pleased to have my old friends and colleagues from Egypt and from the USA. And we are going to debate about this debatable subject, which is the fractured neck femur. And I would like first to, like the panelists and the speakers to introduce themselves. So I will start with our chairperson, Dr. Amr Khairi. So can you introduce yourself, please, Dr. Amr?
I'm Dr. Amr Khairi, the head of the orthopedic department, and I have the honor for this. I have an idea 3 months ago to start a platform for these webinars to make help in dealing with all sub-specialties and to increase our learning curve, which we are very careful in Ain Shams University. And I hope I wish to have this goal successfully.
Okay, Dr. Tariq Sami.
I'm so delighted to be among the panel today and share the experience of this very exciting subject with everyone. I'm so anxious really to hear about the experience of our fellows in the United States about how it works for them. And at the same time, I'm very pleased to share the younger generation their experience. So let us see how it will go.
Okay, Dr. Ayman.
I am Dr. Ayman Abdelaziz, professor of orthopedic surgery at Ain Shams University in Cairo. It is my honor to be a member of this amazing team, and I wish a fruitful night and for all the audience, and wish all good luck.
Wael.
Dr. Wael Samir Bahiri, professor of orthopedic surgery, trauma, and arthroplasty in Shams University. It is my honor to share my experience and knowledge with our distinguished speakers and the panel, and our friend Dr. Carol from USA. Thank you.
Eben.
You are muted, Dr. Eben.
Oh, sorry. It is my honor and privilege to be a part of this team and to be a part of this webinar. I appreciate the opportunity to discuss what I think to be a very complicated and difficult clinical situation to deal with, and that is femoral neck fractures in our younger populations. I appreciate the opportunity to be a part of the team and look forward to a fruitful webinar.
Thank you. Radwan?
I'm Radwan Mitwalli, Associate Professor of Orthopedics at Shams University. And I would like to thank everyone in this webinar, because I know how much how much was the effort done for being successful. So thank you.
Mustafa Al-Abd, lecturer of orthopedic surgery, Shams University, orthopedic department, Ain Shams University. Very pleased to be among these lecturers and professors, and thanks for this invitation.
Zahir,
Yep.
please, I would like to have another minute because Isawi was not recording my talk, so I will not repeat it, but I will mention some points in less than 2 seconds. Again, I welcome all our colleagues to attend our fixed webinar. This webinar will deal with fracture neck of the femur young adults, the wicked fracture and the unsolved problem. Again, my thanks to our godfather, Professor Hassan Al-Zahir, who made trauma easy for everyone in Egypt. And again, I'm very thankful for our speakers and our panel who already introduced themselves, and we will be in the record. And again, I will be special thanks to our moderator, Professor Hassan Al-Zahir, our trauma team leader and the AE coach. And, sorry for repetition, but he was not recording Mr. Ashley. Okay.
No problem. Now I'd like to start the meeting. Why fractured neck of the femur is so debatable? Why it is the unsolved problem till the 2020, and still we have the same problems that we have faced before, and still we have the same problem. So I will start with this case. It is presented. It was done by Professor Tariq Sami. It is a fractured neck femur, comminuted fractured neck femur, and it was fixed by 4 cannulated screw after anatomical reduction, as you can see there, and after follow-up and 18 months of follow-up. That's what we get. We get a virus. We are suspecting that it hasn't united. Maybe there is some AVN. So why do we get this problem? So I'd like to ask the panelists in general, why do we get the problem with fractured neck femur? Why it is so debatable? So if I'm going to ask Dr. Tariq Sami, I'm not talking about your case, but in general, why do you think neck of the femur is so problematic?
Well, if I would like to start this meeting, I wish to mention that fractured neck femur in this specific group of young adults is somewhat completely different entity of what we see in the elderly or geriatric age group. And incidence-wise, it could be 1 in 10 or 1 to 20 patients.
طارق انت فاتح حاجه ثانيه في صدى عند حضرتك شويه. لو حضرتك فاتح حاجه ثانيه اقفلها لو سمحت.
Okay.
Please go ahead. Please go, Dr. Tariq.
Can you hear me now better?
Yes.
The voice is
Yes,
better
yes.
now?
Yes.
Okay.
The picture is better.
So incidence-wise, we are talking about 5 to 10% of the total number of neck femurs, which happens in this age group. So most of us will see 1 up to 5 per year. So frequency-wise, it is much less than we see in neck femurs in geriatric age group. The second problem, which we have to think about, fractured neck femur in the young adult is a high energy trauma. The quality of bone in this age group to break the neck of femur necessitate to have a high energy trauma. So we have to expect the insult which will happen on the bone and soft tissues is going to give us much higher extent of the problems. The third problem, the demands in this age group is much higher than the elderly age group. So the overall problem is the extent of trauma is much higher and the demands of these patients is much more than the geriatric age group. Okay. So I would say the main problem is the trauma which happened to break the neck of femur is definitely going to give us much higher incidence of complications.
Okay. So, Dr. Ayman, we are talking about young age groups. What is the definition of young age group? Because I think it is different from Egypt, from United States, for example. So, in Egypt, what is meant by young age group?
The question for me or Dr.
Yes,
Ipin?
Ayman.
For me.
Start
Okay.
In Egypt, what do you think?
I think we are to a little bit different from the international definitions. So if we stick to the physiological age, I think we can consider the younger age group in Egypt is between around 20 to 50 years old, which I can consider them young. I consider that they have long expectations or higher expectations for recovery. So we can, I can define the young adults in Egypt according to the physiological state to be the age from 20 to 55 years old.
Okay, Dr. Eben, do you agree about this age group, or is different in the States for young adults?
Good question. So I think more and more in the at least in the United States, I think that we're really focusing on not so much chronologic age but physiologic age, and it seems like more and more the definition of what is an elder or an older femoral neck fracture keeps getting pushed to higher and higher ages. So classically, people sort of drew a line at the age 55. That was sort of an age where you had people younger than 55 were considered young, and older than 55 were considered old. That age seems to be being pushed to older ages. Some people are using 60 or 65 as the definition of a more elderly patient. And I think the overarching idea is that we really try to focus more on the physiologic age as opposed to the chronologic age.
Okay. But if I may ask about physiological age and chronological age, does it make a difference if we have, for example, 60 years old patient with neck femur fracture? Does only the chronological and physiological age differs, or the quality of bones differs? Because it's more about the quality of bone, whether the screws is going to hold or the fixation is going to hold or not. So how can we assess the quality of bone before doing the operation? Is there any way to do this?
I think the mechanism of injury is a good thing to help guide us. All these, I suspect a lot of the cases where we are going to see in this webinar will be a result of high energy motor vehicle collisions or high energy motor cycle collisions. And so in that age group, I think it's safe to assume that the bone quality is better. If you have someone who sustains a femoral neck fracture from a simple fall, regardless of age, I think that that's someone who has may have worse bone quality and fall into the older category.
Good. Okay. So now we have focused, guys, about the problems that we are facing, and as you have seen and heard that it's a troublesome fracture. So now for the audience, I'd like you all, if you have any question, you can write it in the Q&A box. And if you have, or you can raise your hand, and one of the, and we are going to ask you to tell us your question. We are going to open your mic for you, and we will ask you to tell us your question. Also, some question we wish you that you can answer it on the chat box if you could not answer, so that we can have some interaction. So if you have a question, please raise your hand. With the head and the raise hand sign, you can do it, and we give you the mic to talk, and we open the mic for you. Now I'm going to stop sharing, and we start the session by Professor Dr. Radwan. Start his first session. So Radwan, please go and share your screen about the first session.
So we will start the first session as regard the fracture personality and the reduction. And we are going to present these three cases. The first one is with a vertical fracture line. The second one is a valgus impacted. And the third one is a displaced subcapital fracture. So can I ask the moderator to do the polling?
Please do it. Yeah. You do it. We have some question and some polling. We need to take the opinion of all the audience about some question here. So the first question, the first poll, please do it, Radwan. It is about would you do it? Yeah, go ahead. Go ahead.
Are these pre-operative imaging as regard the X-ray, the anteroposterior and the lateral are enough for you to decide your operation?
So here's a question: does it make a difference if you have another X-ray, or you have made your mind directly that that's enough for me? I will go and fix. Okay, so can you end the polling?
We are going to end the poll.
Can you show the results? So it seems that 75% are not satisfied with just the X-ray, and 25% needs another, are satisfied, and that's enough for them. Okay, so let's see. Next question. Next question.
Okay. So the second question is when to perform this surgery. Do you prefer to do it within 6 hours from the injury?
Can you launch the second question? Oh, yes. So when to perform this surgery? That's a question. If you have a patient who came to you, are you going to do it within the first 6 hours? Will it give us a better results, or makes no difference to do it the second day, or after 24 hours, or even more? Will it affect the results of the patient, the prognosis?
Now we will end the poll.
Okay, so most of you agree that we can do it within the 24 hours, makes no difference. Okay, third question.
What is your mostly used technique for reduction of these fractures, closed or open reduction?
We need you the truth. What would you do? Is it open or closed? Okay. So most of you, as all of us knew, and all of us maybe are following the same, closed reduction is our primary choice, and open reduction, we don't use it a lot. So, but I hope by the end of this session, we can change your mind a little bit. We can give you some ideas about why it is preferable to do it, for example, 6 hours, or not to do it 6 hours. So let's start our session, and we hope that we can change your mind a little bit. Go ahead.
So the first case was a female patient, 43 years old, who had a road traffic accident, dashboard injury. She complained from right neck of femur fracture. She does not have any associated injuries, and she is with a medical past history free. It was classified as garden type 3, displaced fracture, and Powell type 3. So,
Okay.
Dr. Zahri, you can moderate
yeah. So now we have this vertical fracture, and it is Powell 3, which is the worst one. So if I ask the panelist here, Dr. Wael,
Yes.
does it make any difference the classification for the decision making?
Yes. One of the
or before the decision, does it make a difference as the outcomes? So are you going to tell the patient about anything more, or you?
Yes, there is a big difference in the results as regard the avascular necrosis non-union between displaced and non-displaced fracture as Gordon classification, 1 and 2 non-displaced fracture, 3 and 4 displaced fracture. And the most important is the biomechanical difference in classifications by the Powell. As we see here, this fracture is subjected to a very high shearing force, which the patient will be subjected to the high incidence of non-union, difficult reduction, and maybe failure of the fixation. So in such cases, you change your mind as regard the closed versus open. Closed may be not enough and should go for the open reduction. The threshold for the open reduction should be low. There is no accepted reduction, should be anatomically reduced. And you should use one of the implants that would withstand this high shearing force in this type of fracture.
Before jumping to the reduction techniques and fixation.
Okay.
So now the fracture pattern will affect the outcome or not?
Yes. The shearing force in Powell 3 would affect them with high incidence of non-union and avascular necrosis in comparative to the Powell 1 or 2.
Any one of the panelists would like to add about this? Will it differ in the? Yes, please, Ayman.
Okay, for sure, the classification has its effect on the management and in the outcome. For this type of fractures, we have, I agree with Wael, we have two problems here. One is a biological problem regarding the vascular injury, which may occur with this fracture as regarding kinking of the metaphyseal vessels. And so we have a problem as regard the healing. Also, it has a mechanical issue, biomechanical issue. So it will affect mainly on the way how to fix this fracture. We have to keep in mind that we have to do a stable fracture for this. Anatomical reduction is the rule in all types of fractures. There is no specific criteria for this type, but we have two main issues: the mechanical one and the biological one.
Okay. Evan, anything to add, or that's
No, I think that's been summarized very well. I agree. What concerns me most about this fracture is the verticality of the fracture. As our panelists have alluded to, that is going to see a lot of shear. And so that may alter or change the mechanical construct I'm going to use to stabilize this fracture. I'm really going to try to think about how can I neutralize or prevent that shear force that this fracture is going to see from making my outcomes not good.
Okay. Radwan, about the imaging, you have asked a question here before. So it's enough to do a plain X-ray. Will it do another X-ray? Will it add anything more? It's very obvious that we have a shear fracture and it is a displaced fracture. Do we need another X-ray?
I think we can see here that the lesser trochanter profile is obvious in the X-rays, and this means that the limbs are in external rotation. So this is the not normal position of the limb. So I would ask the panel: do you prefer to do a traction internal rotation to show the verticality of the fracture line better, or do you want to do a traction view? So, Dr. Wael, do you prefer to do this
yes,
traction internal rotation?
In my routine practice in fracture neck femur or proximal femur, I asked the resident to go for a traction X-ray to show the reducibility of the fracture to the exact bowel angle. As you know, the bowel angle may be different by the rotational view of the X-ray.
Okay. Do you agree about it, Eben? Do you do a routine traction X-rays?
You know, another bit of radiographic information I would really like in this case is for me, I find a CT scan helpful to help me understand the fracture pattern and where the comminution, if it's present, may be. So a CT for me would be something that I would potentially like in this case.
But you don't do a traction X-rays, okay?
I do not routinely do traction X-rays in femoral neck fractures. In other peritrochanteric fractures, but not as much in femoral neck fractures.
Okay. So now,
Dr. Zahir,
yeah.
I want to ask, please, Dr. Wael, does the patient suffering during this traction X-ray deserve, you are going to change your opinion or your technique?
It is about the reducibility of the fracture. The difference here is the rotational errors may be detected by the rotation of the femur, so it may be deceiving.
Let's talk practical reducibility. This you can do it under image intensified while the patient is anesthetized.
It makes
does it work to make him have some pain during admission to know fouls how much 60 or 40?
It is a little bit traction, no much pain, because routinely in my residency we do a pre-operative traction. We stop it now, but pre-operative traction to relieve the pain. So that does not increase the pain during the X-ray to do a traction. As Eden said, we do it routinely in intertrochanteric and peritrochanteric fractures. The same idea. It gives me idea about how I will proceed for only closed reduction. So I will use a traction table. If it is not reducible fracture, and the fracture is difficult with this traction injury, so I will not use a traction traction table during surgery. I will go for ordinary because I have high incidence to go for open reduction. This is the difference for me.
I am now convinced. Okay.
Okay. So now let's go for the next slide. Go ahead, Radwan. For this patient, a CT scan was done. Can you show the CT scan, Radwan? Okay. Can you Radwan, can you iterate on this CT scan?
In this CT scan, we can now see the verticality of the fracture. It's almost 70 degrees. Yeah. And in the 3D ray format, we can see that there is a posteromedial comminution in the fragment attached to the head. And this may be a cause of complicated reduction or fixation for the patient. So the CT was of value for me.
So was it of value for the reduction technique, or was it value for the fixation you are going to use? What is the value here? What is the value of CT here, Dr. Ayman?
I think the CT will not affect my decision as regard the reduction. I think it will judge me and will direct me to the way of fixation. This is
so how are you going to reduce this fracture?
This is a typical deformity that can be seen in this type of fracture in the CT, the anterior angulation and the posterior comminution. I always start with a trial of closed reduction in my practice. I go for open reduction, but I usually start a trial once for closed reduction guided by the X-ray. Usually we put the patient not on the traction table, but I make traction, abduction, external rotation to this impact, and then internal rotation, and take an image picture, and then proceed either for open or closed reduction.
Okay, Dr. Tariq Sami, you are a fan of closed reduction. Would you go for a closed reduction here?
Well, I think this case is very deceiving and very wicked wicked case, because if you will see the plain X-ray for an amateur or for a beginner, it will look as if it is very simple to do a closed reduction for it. But the CT scan is obviously showing, even if I can get a good position under image screen, it is going to be very unstable later on. So definitely this case is not for a closed reduction. On the contrary, I would think about open reduction from the very beginning.
Okay. So we all agree that it needs a reduction. And whether open, whether Ayman has said that we can do it as trial closed, and if failed, you can go for, we'll jump for open. Dr. Tariq said that we need an open reduction from the start. So when should we do the reduction? Will we do it early within the 6 hours, or we can do it at the early in the morning in the list? What is your preferred timing to doing this operation, Dr. Tariq?
Well,
will you as in another way, would you, if the patient here came to us at 5 p.m., would you feel guilty if you do it the next day?
Well, I consider those cases not simple cases to do at any time of the day. On the contrary, I would be very pleased to have all the assessments and all the assistance for me ready for those cases and well prepared. So I wouldn't consider it is an emergency situation to go for the first 6 hours. I would rather prefer having the best setup for the theater and the best assistance available and the best mood for me as a surgeon to start the day with. So I would consider it much more kind of cases which I would prefer to start the next day with it. So I wouldn't insist doing it on the first 6 hours unless the patient is pretty lucky and came at an very optimum time and everything is prepared. Otherwise, I will set it first case on the second day morning.
But my question is, if you are going to set it for the next day, would you feel guilty?
No. Statistically, it didn't make any difference whether to be done in the first 6 hours or the first 24 hours. So I wouldn't feel guilty at all. No.
Well,
I think there is a change in our practice as regard the timing of the neck femur. 20 years ago, it was considered as an emergency fracture and should dealt with within the 6 hours to do a reduction. Nowadays, after large studies of meta-analysis and maybe prospective randomized study, they don't found a big difference between before 6 hours and after 6 hours. But the general consensus that we should do within the 24 hours. With no major difference between.
Okay. It's my next question. Now we took the patient to the OR, and one of the proposal is to do whether closed or open to do a capsulotomy. Would you do it as a routine? Eben, would you do a capsulotomy as a routine, whether it is closed or open for this patient, so to relieve the tamponade which is present?
You know, I think that for me, a fracture like this probably is an open reduction. So if I'm going to do an open reduction, that makes that debate a little bit, not applicable. As I'm going to be opening the capsule anyway. But I think even in fractures which are valgus compacted or non-displaced, or for whatever reason, if I get an acceptable closed reduction, I think it's not that much more surgery. It's not that much more invasive to simply slide a scalpel blade on the anterior femoral neck to make a cut in the capsule. There is data to suggest that may make a difference. And again, it's something that I could do under fluoroscopy without making a much larger dissection or incision. So even if I'm not going to open reduce it, it's something that I strongly consider.
Okay. Any
one of the attendees want to ask a question, Dr. Rami Sliman.
Yeah, please.
Okay, I will allow him to enter with us.
Yeah, allow him to speak.
Rami.
Got him?
Rami.
It is not working.
Rami.
But for the Egyptian panels, it is a routine to do a capsulotomy with the closed reduction, Dr. Tariq?
No, actually, I know it's written, and there is a lot of a sense of making it, but to my mind, I don't think such fractures, after having this kind of trauma, would leave the capsule intact, so that just sneaking the knife over the anterior cortex would make any difference regarding the decompression of the capsule. I don't feel really it is something mandatory to do, and I don't think it makes a lot of difference in the prognosis.
Ahmed Al-Sawi from Elixir. Ahmed.
العيسوي.
عيسوي.
دكتور مع حضرتك يا دكتور زاهر.
ممكن تخلي الدكتور رامي هو he is raising his hand يتكلم to allow him to speak.
The option on the application is not working. The option
written question.
Okay, I already texted him. Yes.
حضرتك عايزني اخليه بس allow to talk ولا ادخله؟
allow to talk. اوكي.
دكتور رامي ممكن تاكسبت ان انت تفتح المايك؟
رامي. It's not working. طيب.
I think we have to move.
هدخله بدل وارجعه تاني. اوكي.
طب It will take time. خلاص, if it's not working, okay. You can write it on the chat or the Q&A. Rami?
Let's move.
I will text him. Okay. I will text.
Let's move, please.
Okay. So let's go ahead. So capsulotomy is not favorable to everyone here because it's not worthy. So let's go. Radwan, we did. Radwan?
Yes, sir.
Can you go ahead? Move.
So,
Dr. Zahar, can we ask Eden about the absolute indication for open and the absolute indication for closed reduction in his hand?
Okay. Eben.
Yeah. So in my hands, I think that an attempt at a closed reduction is very reasonable. I think we all would agree that reduction is more than anything is what's going to drive success or failure for this patient. So
Eben, please, your sound was better before. I think you have changed something in your settings.
Can you hear me now?
Yeah, we can hear you.
Yes, we hear you, but it was much more clear before. Okay.
Okay. So I think that I'll step out of this room, maybe it's this room. I think that we would all agree that really what drives outcomes for these fractures is how good the reduction is. No question. And so I think it's reasonable to make an attempt at a closed reduction. I have no problem with that. But I think if you're going to do that, or if I'm going to try that, I really want to be very critical of my reduction to make sure that I'm getting the best reduction possible for the patient. Now, I will tell you that on many occasions, I have had what I felt to be an acceptable closed reduction based on radiographic evidence, based on fluoroscopic images. And then I've opened it and I've been surprised with how non-anatomic my reduction was. So for many of these patients, these younger patients with displaced neck fractures, I'll be honest with you, I have a very low threshold for proceeding right to an open reduction. Now, the literature is a little bit all over the place with regards to this. And what I want to emphasize is the debate is not, for me, is not open versus closed reduction. It's really, yes, it's really, is an open reduction going to allow me to get it anatomic? And for me, I feel like if I'm looking at it and able to manipulate those fracture fragments, I'm better able to get an anatomic reduction or assure an anatomic reduction with an open approach.
Okay. So in this case, what happened is a closed reduction and they get.
Dr. Zahar, can I ask a question?
Yeah, please.
Okay, this question for you, Professor Zahar. Do you believe on what we call acceptable reduction in this type of fractures?
No.
Do we have a definition for acceptable reduction?
For neck of the femur, it should be anatomically reduced, not acceptable reduced, not in alignment. We need an anatomical reduction because it affects the results.
We don't have what's called acceptable reduction in this type.
Yes. Well, and it's very important point that even the deceiving points or views of the image intraoperative.
Yeah.
Sometimes you see this reduction is nearly anatomical, but actually it is not.
We'll show you what Eben is saying in one of the slides later on. So that's the anatomical reduction. It seems anatomical for us. and that's temporary fixation. And we are going to stop here for this case and jump to another case. And we are going
how can assess the reduction, Dr. Zahar?
Okay, how can you assess reduction? If I'm going to ask you, I go back, Radwan, please.
Go back. I think I have to do to make sure the X-rays or the imaging are good. We have to ensure that it's a true EP in internal rotation and the lateral view is a dead lateral view. And so we can rely on what the Radwan drawn on this image. This is Lowell's lines. It has to be S and inverted S in both views. And also we have the neck shaft angle, or if we can see the garden index trabecular bone of the neck with the shaft of the femur. I think this will be a landmark, good landmark for anatomical reduction, or what we assume to be anatomical.
Yeah, but usually the image intensifier, as Wael have said, is very deceiving.
Usually misleading to some extent.
Yes, very deceiving.
One of the important trick I used nowadays, but it needs a highly specialized hospital, and if you can use two images at the same time, I use one image from the other side, from the abdomen side to for the AP, and the other for the lateral, and fix this setup before you go for the operation, before sterilization at all. So that both images are fixed all through the operation. You don't need to go through between AP and lateral. So at the end of the surgery, you don't find the exact lateral view you achieved pre-operative. Okay. You should fix the image intensify.
Another thing that I am insisting on, sorry, Turan. And I'm always telling my assistant to not to accept to start without a good image, without a complete view of the EP and the complete view of the lateral femoral head.
Yes,
so you have not to start the operation until you have this good image.
Okay. So, we have a question from Dr. Abdurrahman. Can you talk now?
Yes, sir. I'm asking about the best approach in such case with vulnerability for the vascularity of the head of the femur. Usually, we are used to the standard Watson Jones. If we decided for an open reduction, is it accepted to go for an anterior Smith-Peterson approach?
Okay. Can we? We are going to ask this. We are going to answer this question in the second case. So a good question, but we are going to ask it next for the next. You are going to get the answer. Okay.
There is another question, Dr. Zahar. From Professor Dr. Wael Nassar.
Yeah, please.
The question is, what is the role of navigation in order to solve the problem between closed and
background يا جماعة. في صوت background please. اللي في عنده الباك يحاول يحله لو سمحت.
Did you hear the question, Professor Zahar?
Again, please.
What is the role of the navigation to solve the problem between when to do open, when to do closed, or to know how we can reach more accurate reduction with the navigation, either with closed or open reduction?
We don't have an experience in navigation. Eben, do you use navigation for the neck femur?
I do not have experience with navigation in the neck. No.
No, it is not commonly used.
It's not used. It's not commonly used in the neck.
Yeah.
It's not used anywhere. I don't know to my mind where it is used. This navigation.
Yes.
Okay, let's go.
So next, we'll shift to the next case. Radwan, please.
The next case we will start with again a polling.
Yeah, polling. Yes, go.
So I ask the participant to answer this question. Shall we do reduction in valgus impacted in young adult neck of femur fractures?
Yes, that's a very, very tricky question. When we have a valgus impacted fracture, do we need to do a reduction, or would you accept the situation and do pinning in situ? I want the common practice. Okay. So 60% say no, we don't accept valgus impacted, and 40% say that that it is acceptable and we do it. So can one of the Yeah, wait a minute. One of the guys who said we don't accept it. Can he raise his hand and you can tell us why? One of the audience who said that he would Ahmad Hassan. Yeah, allow him to talk. Unmute. Ahmad. Yes.
Yes. Good evening. I will not accept this actually because there is chance of deterioration of this for another or poor deformity more.
More deformity? Why? Why would it happen?
This actually it complicates also the reduction.
Okay.
Complicate the reduction.
Okay. So another one raised hand, Dr. Muhammad Wafa. Allow him to talk. Yeah. Dr. Wafa. Yes.
Hello, everybody.
Hi.
How do you do? Yes. Hello. The question was, would you do a reduction in this case or would you not? No,
Yes.
we don't do reduction. We just accept it as it is and fixed as it is.
Even in young adult?
Pardon?
Even in young adult?
Yes, sure, in young adults.
Okay.
Can I have a comment?
And we'll try to compress on the lower part of the fracture or on the calcar.
Okay.
And then it would do very well.
Good. So let's have Eben. What's your opinion?
وائل كان عنده comment يا دكتور زاهر.
Oh, sorry. Okay. وائل first, yeah.
احنا first we should have a consensus about the definition of valgus impacted. Valgus impacted means that we have a valgus in the AP but completely reduced anatomically in the lateral.
Yep.
If the neck is going for retroversion or antiversion, it is not, by definition, it is not valgusly impacted. So valgus impacted have a condition that it is only valgus in the AP and the lateral, no displacement at all. If displaced, it is considered a displaced neck femur fracture.
Exactly.
Usually impacted fracture occurred in elderly patients more, in 60 and above. Not usually we find this fracture in an young patient, as we said by Professor Dr. Tariq Sami, that is usually it is a high energy trauma and usually it is not impacted, valgus impacted neck fracture.
Okay. Eben, any comment?
Yes, I agree with Weil 100%. I think what's critical to assure, if you're not going to do a reduction on a fracture like this, which I agree with, if it's truly valgus impacted, I consider that to be a very mechanically stable situation. I don't want to create instability by disimpacting it, but you need to assure that it's a uniplanar deformity, that it's only valgus in the AP. If there's any posterior roll-off, and I think that I'm surprised how common posterior roll-off and sagittal plane deformity can be in these injuries. If there's any sagittal plane deformity, then I think you need to reevaluate and consider doing a reduction. But if it's truly just in valgus impacted, then I will leave it and fix it in situ.
Okay, good. Radwan, you have anything to add here?
I will show
it is the same case.
I will show it in the evidence.
Yes, we'll show the evidence exactly. Okay. Go ahead.
Question from one of the
Yeah, go ahead.
Allow him to talk.
Yeah, unmute. Okay, Dr. Muhammad.
Good evening, everybody. The fracture, we can accept this fracture, valgus impacted, as long as the fracture, if fail, it will fail into varus. So we have to accept this fracture without making any reduction.
Okay. So that it's as the panel have said, it can be accepted. At the end of this session, we'll have some reference and some evidence about whether to accept or not, and there is even some debates on that. But
yes, thanks.
Okay, thank you.
Thank you.
Okay, Radwan.
This is our last case for a female patient, 39 years old. She had anatomical subcapital fracture, garden displaced, and here is a view with external rotation of the leg. so we cannot judge about the Powell classification, and no available CT scan for this patient.
Okay. So, Eben, I know your opinion, but when you see this case, you go directly for an open reduction.
Yeah, for me, 39-year-old, with that amount of displacement, I feel more confident in my ability to obtain an anatomic reduction if I'm looking at it. AO, you could treat this like an articular fracture. AO principles have always told us that we look directly at articular fractures and get them as anatomically reduced as possible. And for me, at least, this is no different. So I'm going to open reduce this. So
any one of the panelists will go for closed reduction here, or even trial closed reduction, or so you all.
In every single case, I will go for attempt for closed reduction, and if failed, I will go for open reduction.
So you are going to have an attempt.
I think I agree with Wael. I cannot judge on this X-ray only. I cannot take a decision, but I don't lose anything when I'm trying once for trial closed reduction, and it may proceed or not. I will go for open reduction.
Okay, Ram.
Yes, my dear.
Any comment?
No. Okay. I'm agree.
Okay. So go ahead. Go on, Radwan, please.
This case have been done by an open approach, the Watson-Jones approach, in a supine position without traction table, and this is the immediate post-operative.
So wait. Can you go back, please?
Okay.
Can you go back? So now the surgeon here have decided to do an open reduction, and Eben decided to do an open reduction, and most of you agree that it is an open reduction. So which is your best approach? We have, for example, Dr. Tariq Sami was used to do an hard-hinge approach, and we have another two approaches, which is the anterolateral and the Smith-Peterson. So what is your preference here? So can Dr. Ayman, what would be your preference?
My approach in these cases will be Watson-Jones, and I can go for the fracture directly, and I can reduce it from the Watson-Jones approach.
Well, and you can fix it easily, Ayman. Oh. And also you can fix it easily.
Yes, that's from the same incision. I don't need another incision.
Yes. Okay. Yes. That's what I'm going to add. Yes.
Well, same approach.
Yes, routinely we use Watson-Jones approach in our practice for reduction and fixation.
Dr. Tariq Sami.
Well, I'm really a fan of the Harding approach in most of the neck femurs, unless it's very high and subcapital. Otherwise, I do Harding approach for the ease of access to the lateral cortex and the ease of insertion of implants, especially if I'm using a sliding or dynamic hip plate.
Eben.
For me, my preferred approach for open reduction is the Smith-Peterson approach. That does obligate you to do a secondary accessory incision to place your hardware through. So I sort of think about it as my Smith-Peterson approach is my reductive portal. And the reason I like the Smith-Peterson approach, at least for me, it allows me to look straight down on the fracture. So Watson-Jones, you're coming in at a slightly kind of lateral to medial trajectory. The Smith-Peterson is straight A to P. So I feel like, at least for me, I get better visualization of the fracture and I'm able to manipulate the fracture better. That's the upside for me. The downside is that it does obligate you to make a separate lateral incision to place your hardware through. So it's a dual incision approach, direct lateral for hardware and Smith-Peterson for reduction.
Yeah, I agree with you that Smith-Peterson, that you are over the fracture site and you can control the reduction more. But Watson-Jones is also used, but that's usually surgeon preference here. But usually I agree with you, Eben. So here, despite doing an open reduction,
can we ask Dr. Zahir, one of the participants, to comment on the reduction of the fracture?
Yeah, please. Yeah. Who can comment from the participants on the reduction here? Can one of the participants comment on the reduction? Can he raise his hand, please?
You can write your comment on
There
the
is
chat.
one. There is a question from one of the participants by Hussam, but he's asking about how to correct the retroversion with closed reduction.
Okay. Dr. Tariq. Dr. Tariq.
Well, there is definitely limitations of doing closed reduction with this kind of anterior apex deformity or the posterior rolling of the head. So if I am doing a closed reduction and I'm ending up in a situation where I'm having a perfect AP view, but on the lateral projection, I'm having doubts about having a posterior rolling of the head or this kind of anterior apex deformity, I change my tactics from closed reduction to doing open reduction.
But what is your tactic to reduce the retroversion when you have some, which is very common to see?
Well, if I can manipulate the trochanter and pushing the trochanter up, and you see, you don't have any control over the head. So all what you can do is with the distal fragment. So if I can manipulate the trochanter with my hand and try to push it up, and try to rotate the leg internally, this is the best you can do. If you would like to do a low invasive procedure, you can get into the proximal fragment in the subtrochanteric area with a kind of joystick like Kirschner wire or Steinman pin and try to manipulate it. This is the best you can do. Otherwise, I would think sometimes you can correct it, and once you leave it, it roll back again into the posterior position. So I would say if you would suspect it is going to be unstable, there is no point of going into closed procedure anymore.
Okay. So I think that's why Eben is not happy with the closed reduction, because usually you cannot control all the reduction, your own reduction. So that's why he is more fancy to do a very open reduction for most of the cases, especially in young adults, to achieve an anatomical reduction. So and retroversion is one, or sagging is very difficult to reduce with the with closed techniques, and that's why some of us may accept some mal reduction and prefer not to use the open reduction. So that's why Eben, I totally agree with Eben that open reduction is even it is very difficult to do an open reduction. It is not that easy. So let's proceed, because most of the okay, Radwan, you have asked the question, and I think most of them have told you that it is not.
Dr. Zair, I can see a lot of comments from the audience on this X-ray. Can you summarize it, Mustafa?
Some of the attendees think that this retroversion that happened during open reduction was due to posterior cortical comminution. They are commenting about the fixation, that it is not an optimum fixation. While we are in this session, we are discussing the reduction. Would you comment, Dr. Zahra, about this posterior comminution?
Definitely.
Asked by the attendee.
Yeah, but here comes the problem of how to do an open reduction and to obtain the anatomical reduction via an open technique. And I think we are going to have a case with that and explaining how to do it, even if there is some comminution. We have some tricks to do it, okay? So if you can wait for the answer of this question to the next section, okay? To the next case. Okay, Radwan, yeah, go ahead.
So with this malreduction, the 3 months post-operative follow-up X-rays showed some displacement, and again more displacement at 5 months. And lastly, at 7 months, there is a failure of the fixation with more retroversion and non-union at the fracture site.
So, Dr. Tara, why do you think it failed?
Well, the question for me or for Ibn?
Yeah, Dr. Tarek. Yeah,
yes.
Yeah.
I think the early sign for failure was the retroversion of the head from the very beginning, and having nothing to support the posterior cortex. Definitely, it went into more retroversion in the next 3 months, and obviously this was complicated with a kind of non-union. So the backing out of the screws came out from the 5th month and became evident on the 7th month. So I would say it started as a mechanical problem, but with non-union, the problem perpetuated and ended up into backing out of the screws and definite non-union of the head.
Okay. Eben, yeah. Eben, I have lost something. Eben, any comment of the cause of failure here?
Yeah, so it was certainly a difficult fracture from the beginning, and you know had biological and mechanical problems to begin with. But I agree. I guess if this were my case, I would maybe look at the postoperative films and just try to really critically think if there was a way to get a better initial reduction, especially in that sagittal plane. So
Eben, if I may ask you, when you get this, when you next day in the morning and you see this X-rays, and would you go ahead and do a revision directly, or would you accept it and wait and see?
That's a good question. I think that's a discussion that needs to be had with the patient, and again, I think the surgical team needs to kind of assess whether or not there's something that they can do different to achieve a different outcome. But I think that this outcome was somewhat predictable based on what that sagittal plane looked like. So a short answer to your question is if I was in there and I did my best and I felt like I gave it my all and I couldn't get a better reduction, I would not take it back. But if there was something that I didn't recognize, or maybe a technique that I didn't think about that I felt like would improve the reduction the next day, I would have no problem taking that back.
Okay. So
there's a question,
Dr. Zahir, I have a comment in this case. This shows us the importance of the CT scan. I think we didn't do a pre-op CT scan in this case. Am I right?
Yes. What is going to add here?
To add to me, if there is a severe or a considerable posteromedial defect or posteromedial comminution, then I have to deal with this posteromedial comminution. I'll just not go and put my implant and go home. Never. So I have to go for a medial plate. I have to go for any other implant. Yes. And again, when I have such a fracture after post-operatively, I have to do another CT scan to see, is it because of antiversion? Is it retroverted, or it is displaced? It will make me a lot of a difference to make my decision. Shall I go for a medial plate in presence of this fixation, or shall I change my fixation, or shall I accept it?
Okay.
And do non-weight bearing?
Okay. If I may, we are not going to talk about the fixation here. We are going to talk about next session. But usually the medial plate does not work in subcapital fracture, because that's intra-articular fracture now. So we don't use the medial plate on subcapital fractures.
May I ask a question?
Dr. Zahir, we have questions.
I ask one question. May I ask for the panel? We don't talk about fixation here in this session.
Yes.
But what if we using here DHS instead of pinning in this fracture with subcapital fracture? Is DHS will tolerate the shearing more than the pinning? As we know, the pinning is not tolerate to the shearing force, but DHS is more mechanically stable. If I have this case, the DHS can tolerate little bit displacement at the fracture, which is not anatomical fracture, then the pinning. This is my question: the relation between the implant and the reduction.
Can we ask this question? Can we remember this and wait till the next session, please? So so Eben, would you put a medial plate here in subcapital fracture?
So one thing I worry about with the subcapital fracture, and someone mentioned a sliding hip screw, is there's really a tendency for that sliding hip screw in this particular fracture pattern, especially, to rotate that head segment. So that may not be the fixation construct that I would choose to fix this fracture. And I think it, as far as the plates, I mean, I think it depends where the comminution was. If there was some medial calcar comminution, or even posterior medial calcar comminution, if I could get to it, a good way to contain that comminution and to reestablish a calcar and reestablish a bony buttress to varus collapse is to use a mini fragment plate. So I know we're going to talk about fixation constructs in a little while, but this fracture in particular, I'd be a little worried about using a classic sliding hip screw in.
Okay, Radwan, please go ahead. We need to finish this session.
Questions from the attendees, Dr. Zahar. First question.
I didn't understand Eben carefully, Dr. Zahar. Eben mentioned he's against DHS, a dynamic hip screw, but I think he's to do a medial plate.
If it is a calcar, post-medial comminution at the calcar level.
Yes, he will use a medial plate.
Yeah, but here we are. It is very high from the calcar here. I'm right, Eben?
Yes. Yeah. Yeah. It would be hard to get the proximal aspect of that plate on the head to get fixation in the proximal segment. Yeah. For more lower fractures lower down the neck, basocervical or transcervical.
Okay.
Okay.
Can we shift now, Mustafa? Any question or?
There is a question from one of the attendees. How can you assess lateral radiological lateral view in the supine position without a traction table? Another question, if the problem is with retroversion and you have only the access from an anterior approach like Watson-Jones or Smith-Peterson approach, do you find, is it somehow difficult, or it is not a direct access to the problem, as the deforming forces are mainly retroversion and you are accessing it from anterior, either Watson-Jones or
let's wait for the other case that's going to show us how to make some tips in the reduction. Okay, especially this problem. Okay, so Radwan, please, can you go ahead, please?
So, thanks for the panel for the debatable issues. We have heard about some of the debatable issues, and we should now know what the evidence is telling us. I will start with the preoperative imaging. And as we have seen, the traction internal rotation view have been evidenced to facilitate the explanation of the verticality of the fracture line and the easiness of reduction for the fracture. So some of the evidence recommended to do it preoperatively. And of course, the best tool for evaluation is the CT scan. The second issue is the classification. And by logic thinking, and from years ago, we know that displaced fracture and vertical fracture lines are unstable fracture patterns. And of course, they will lead to malunion, avascular necrosis, and non-union. We depend for the classification of the amount of displacement on the Gardens classification. But from very old, it have a poor inter and intra reliability, up to only 22%. That can be increased to 77% when we are going to talk as if is it a displaced or not displaced fracture, not linking to the 4 grades of the Gardens classification. Another limitation of the Garden classification is that it does not link the age, the presence of comorbidities, the quality of reduction, concomitant injuries, which is other co-founders of the morbidity and the functional outcome for the patient. But the most important is it does not tell the anatomical location of the fracture. It does not differentiate between the subcapital, which we know it has more complications, from the transcervical fracture. Actually, the systematic review done in 2018 have found that there is no link between the avascular necrosis or non-union to Guardian's classification, supported by 7 papers. And another paper that have been published in 2019 have supported the same results. The same could be seen for the vertical fracture line, which is the Powell's type 3. And again, the verticality of the fracture line, displacement or comminution cannot be a risk factor for the development of avascular necrosis and non-union. So what is going on? Recently, in 2020, a study have been done as regard the vascular injury at time of the injury, and they have subclassified the patients into 3 groups. The first of them, when we have a kinked vessel like this Guardian type 3 fracture, and we have no vascularity to the head, but simply by reduction, we can regain the vascularity of the head. Type B, in which we have an avulsion of the superior truncular vessels, and although there is no much displacement at the fracture site, we can see that reduction may not help the patient, but only if we could allow a strong stability at the fixation of the fracture, we can have revascularization buds and intraosseous vascularity to the head. The third type, when we have a rupture of the superior truncular vessels, and here we need a microvascular surgeon with us to do the anastomosis. So it's clearly that there is no link between the Guardian classification and the amount of vascular injuries that's happening. And the most important, that we should do a good reduction and give strong stability for the fixation. The third issue is the timing of the surgery, and a systematic review that have been done in 2015 have found there is no link between the timing to the surgery and avascular necrosis. But they said that we have increased odds of non-union when we are dealing with the fracture in a delayed fashion more than 24 hours. But actually this paper is depending on one paper to have this clue. Recent publication done by a Turkish group have found that there is no link between the time to surgery and non-union. They were dealing with delayed presentation of cases. Of course, we can expect that we cannot find a publication of such a delay from the Western countries, but actually this is supported and the results were reproducible from another 2 groups, one from Saudi Arabia and the other from the Brazil. So they have emphasized that the most important issue is the quality of reduction, not the time to surgery. To do this surgery at night or the next day, a large publication on 2,334 patients have been done to compare the results if we are doing this surgery at the usual working hours or the after hours or at the weekends. And they have found that there is no difference as regards the complication rate. But actually this paper have a selection bias as the number of group 1 have a significant higher patient than group 2. The risky patients were operated at the usual working days, and this paper is not specific for fixation. So when we are preparing to do an anatomical reduction for these fractures, we need all the instruments, all the capabilities, and a senior surgeon, anesthesiologist, and nursing system with us, because our aim is to have an anatomical reduction. And this publication comes from the Center of EPIN, and they have stated that this surgery is not a surgery done at night. The fourth issue, and I think the panel was believing in that there is no clinical proof to doing a capsular relief if we are going to do a closed reduction, and actually the evidence are supporting not to do it.
Irritated with people opening.
The fifth issue was about the second case. If you remember the case, the valgus impacted in the young adult, and this study coming from the Hospital for Special Surgery are saying that 75% of patients will have radiological camera.
Well, you don't know when it will open. You don't know if
it's angle, the asphericity of the head, and the retroversion, if it is present. And of course, it is increasing if the fracture is in the subcapital anatomical region. They say that if we are not reducing the valgus impacted fracture, the patient might complain from hip pain, decreased scores of functional scores, and of course will go into degenerative arthritis. So they are recommending in young adults, we should reduce the valgus impacted fractures. But actually, when I critically appraised this paper, I have found that the percentage of the degenerative arthritis was in 31% of patients, 10 of them having a vascular necrosis, and they were the major number of patients that had a total hip arthroplasty. And although other patients had the same radiological cam type impingement, they did not need to proceed into total hip arthroplasty. So actually, I cannot recommend whether to do or not to do a reduction for the valgus impacted in the young adults. And we need more research as regards this issue. For the debate between open versus closed reduction, systematic review have been done again in 2015, and they have found that there is no significant difference as regard the number of non-union cases, no significant results as regard the avascular necrosis, and of course, a significant increase as regard the deep infection occurring in the open reduction group. But again, we should remember our aim. Our aim is to have an anatomical reduction, not like the third case. We need to do our anatomical reduction, whether you prefer to do it closed or open. When comparing the Smith-Peterson versus the Watson-Jones approach, you should know that the Smith-Peterson go directly to the subcapital region, so it will explore more of the neck for you to do a better reduction. But if you are going to use a sliding hip screw or to use a plate, you would need an extra approach for fixation with the Smith-Peterson, not with the Watson-Jones approach. The Watson-Jones approach is better for the transcervical and basicervical fractures. And if you are wishing to see more deeper in the head and the subcapital region, you should do a modification with a rectal snip with the rectus femoris. The last issue is the reduction quality. And of course, all of the literature are saying that we should have an anatomical reduction. But actually, all of these publications are based on the classic paper published in the GPGS. But if we look, it is based on patients of the geriatric patients. The mean age of the patients were 71 years. And if we asked ourselves how we are assessing the functional outcome of the patient, most of the literature are not measuring the outcome correctly. Only 31% are including functional outcome scores, and less than 5% have a health-related quality of life scores. One publication have been published in 2018 have found that there is no functional impairment if there is less than 1 centimeter of shortening in the young adults with neck femur fracture. And if it is more than 1 centimeter, there is non-significant decrease in the Harris hip score. And we should expect, as regard the biology of such a fracture, that in the young adults, we will experience some of the shortening. This paper have found it's about 50% to about 5 millimeters and about more than 30% to more than 1 centimeter. This is because of the absorption that is happening at the fracture side, and because we need compression for such a fracture without the extra osseous periosteum that allow union. So we need an intraosseous compression to allow healing of the fracture. So Gottfried have supposed a non-anatomical reduction in what he have called a positive inferior buttress manner. So he now can control the fracture not to be more shortened or going into varus, and at the same time there is some little shortening that is controlled by the surgeon. These results have been reproducible again in 2019, and the surgeon have shown that the amount of shortening and failure of fixation was higher in those who have been reduced anatomically. So of course the anatomical reduction cannot be beaten, it's our target, but sometimes it might be an alternative to do a positive inferior calcar buttress. Of course, we know that the human being is not a machine. It's with more than 3 billion pairs of genes. So if we are going to conduct studies aiming to have the better outcome, I think it's very difficult to depend on the randomized control trials or the systemic reviews. And in such debatable issues, the expert opinion is very important. This is why we are doing this webinar, because the medicine is more an art than a mere science. So to conclude, I recommend to do a traction internal rotation for such patients. And of course, you should have a CT scan for better evaluation of your fracture. The available classifications cannot predict the outcome, so we need a future functional classification depending on the degree of vascular affection. This is not a surgery to be done at night, but still we should do it within the first 24 hours. We do not recommend the capsular release in case of closed reduction. For the valgus impacted, I cannot recommend whether to do a reduction or not. This is need more research. And as regard the closed reduction versus open or the anterior antero approach, I cannot recommend any of them, but our aim should be the anatomical reduction. And lastly, anatomical reduction cannot be beaten as regard to our target. Thank you.
Okay, thank you, Radwan.
Thank you, Radwan.
You took more than 10 minutes. We didn't.
Perfect.
Okay, thank you so
Thank
much.
you, Radwan.
The question from Dr. Osama Shazli.
بس على one comment على دكتور رضوان بتاعت الاوبن versus closed. I think the results are a little bit biased. In all of us start by closed, and then when it is difficult case you go for open. Unless this يعني research have been done يعني without يعني doing case open and the case closed and the case open and the case closed, regardless the severity or the type of the fracture. But to say that open like closed, I think this is a little bit يعني مجحف شويه بالاوبن.
هو الكونسنسس يا دكتور عمرو دلوقتي ان we don't have a place for open versus closed. This is not a question. The question is anatomical versus non-anatomical reduction, whatever the means of reduction.
بس انا بس كنت بعلق على what Radwan have mentioned about they have no difference between open versus closed.
تمام.
Now to conclude this session, Eben is going to present a case in which he did an open reduction, and he's going to explain some of the tips and tricks regarding the open reduction, and most of the question which has been said maybe can be answered here. So please go ahead, Eben, please.
Thank you. Thank you for the opportunity. Before getting started, though, I would like to echo that sentiment that was just mentioned. Almost all these studies that we rely on that say that there's no difference between open reduction and closed reduction are not randomized studies. And it just makes perfect sense that there is a selection bias there, in that the worst fractures are going to get an open reduction, the less severe fractures are going to get a closed reduction, but we cannot compare those two and say that
I agree.
that they behave the same. So I'm glad you pointed that out, because I've always felt like that the worst fractures are going to get the open reduction. The other thing is that I would say, you know, when I start to get in these debates with people about open and closed reduction, and people say, well, the literature is no different. The other thing is exactly, this panel has done a great job of reinforcing what's important. The important question is anatomic versus non-anatomic. So just because you open the fracture, if you don't get an anatomic reduction, or if it doesn't get you a better reduction by opening it, then it's also not going to make a difference. So it's really reduction that we need to focus on, as the panel has very correctly highlighted. So first of all, I really appreciate the opportunity to be a part of this. This has been a very, very high level discussion, and I'll share what little insight I can add to such a good discussion. You know, I'll try to use some examples about talking about how I improve my ability to get an anatomic reduction by opening it. Next slide, please. So let's look at a case of mine. This is a 25-year-old male who was involved in a motor vehicle collision. And as we discussed before, you know, obviously this is a very young person regardless, but even if this was an older person, these are the ones that I think of as younger patients, because it's a result of a high energy mechanism, a motor vehicle collision. You can see that he's got a displaced intercapsular left-sided femoral neck fracture. Next slide, please. On CT scan, we discussed this. CT scan for me is quite helpful to delineate the morphology of the fracture. I can do three-dimensional reformats, as we saw, which really give me an idea as to the exact verticality of the fracture. And then most importantly, the CT scan can help me understand where there's areas of comminution that may require additional points of fixation to reduce and to control. Next slide, please. So you can see here, for example, this is a very vertical femoral neck fracture. Would certainly be a Powell's 3 type injury. And then also there's this medial calcar comminution, right? So right along sort of the mid portion of this neck going into the basic cervical region, there's a comminuted piece, and that is going to become important in this particular case with regards to additional things I may do to try to stabilize and reduce this fracture. Next slide. All right, so here we are. So we talked about many of these things, and I'm going to skip over a lot of the big questions because I think that I couldn't do a better job than has been done to clear up a lot of these debates. Timing of surgery. For us, this patient came in at like 5 p.m. on a Monday. He had a lumbar spine injury, which was deemed unstable by our spine colleagues. And so he was actually going to the operating room on Monday evening to get his spine fixed. And my spine colleague called me and said, you know, Eben, I'm taking this kid to the operating room. He's got a displaced femoral neck fracture. Would you like to follow us and fix his neck after his spine is stabilized? And much like the general consensus amongst this faculty, we felt like this was a surgery to be done under really ideal circumstances with an ideal team and a C-arm tech that I'm used to working with in my team. So we chose to do this surgery the next day. The second topic that we sort of debated was, well, do we do an open reduction versus a closed reduction? And I would just say that I have no problem with making attempts at closed reduction. If you can do a closed reduction, if you can get what you feel to be an anatomical reduction, then that's great. That creates a very nice situation for you and for the patient. That's in my hands with a fracture like this. I just haven't had much luck doing this. More commonly, I think we have a situation like this. So we have to be a little bit weary of our ability to decipher the anatomicity of our reduction based just on fluoroscopy. So this is a cadaveric situation, and what happened was this is a cadaver. This is actually given to me by my colleague Matt Graves, who's at the University of Mississippi. But they created a femoral neck fracture and did a closed reduction on that femoral neck fracture, and this is the provisional reduction in that cadaver. And let's just focus on the AP for now, on the coronal plane. So looking at that coronal plane, I think that most of us would think that that was a very anatomically reduced fracture, that we had done a good job and accept that. And then you go in and you do your capsulotomy and you actually look at what the fracture looks like. And in fact, this is what it looks like. And I would agree that this is not a lot of displacement. This is probably 2 millimeters of cranial displacement on this neck. But what I'd submit to you and what I'd ask you to consider is if this is close, by looking at it and doing a direct reduction, can we get it perfect? And is there a difference in this patient's outcome? Is close okay, or is anatomic better? And so, you know, I just ask you to think about or reflect on the idea that by looking right at it, you may recognize displacement that you do not recognize on C-arm imaging. So we can do the same exercise in the sagittal plane as well. So next slide. So same thing here in the sagittal plane. You can note that I think that looks like a pretty good reduction in the lateral based on the fluoroscopy. But if we actually look at how it looks with the soft tissue removed and looking directly at the fracture, what would be analogous to a direct reduction, we can see that there's some residual displacement there. And again, it's not much displacement, but in these femoral neck fractures in young people, it's a game of millimeters, and a millimeter or two of displacement can mean the difference between success and failure. So I just ask you to think about if by opening a fracture, can I make it better? And if the answer to that question is yes, then you should consider opening it, because it gets down to two variables. Number one is the ability to recognize a non-anatomic reduction. And I would submit to you that it's hard to even with x-rays, even with fractures that look great on C-arm imaging, sometimes you have residual displacement that you can't recognize unless you're looking right at it. And then number two, the other factor is that at least for me, I'm better at getting an anatomic reduction, at achieving an anatomic reduction if I'm looking right at it. Next slide, please. All right, so for us, this was we proceeded directly to anatomic reduction. This is the setup, and I think someone asked about how to get a lateral X-ray of the hip if you're not using a fracture table. You can see that this patient is supine on a radiolucent table, and what I do to kind of help to facilitate that lateral imaging is to bump up the operative hip. This allows you to clear the non-operative hip when you swing to a lateral, and actually the lateral imaging can be pretty good in this situation. We've chosen to a modified Smith-Peterson approach here, as you can see. This is for me a little bit easier reductive portal, so I'm looking directly anterior to posterior down on that fracture, and it helps me to better achieve an anatomic reduction. Again, I am going to have to do a separate lateral incision to get my fixation in, but again, because reduction is so important, I want to prioritize that, and I don't want anything to take away my ability to get this anatomically reduced. Next slide, please. So now we'll talk about, or I'll try to give you a few tricks that at least have helped me when I do an open reduction. So again, the magic is not in opening the capsule. That's going to make no difference for your patient than if you did a closed reduction. The magic is you actually have to get it reduced. So 4 sort of things we want to think about. Number 1 is length. So I don't put them on the fracture table, but if I do find that it's a fracture that needs distraction, that needs traction, I'm quick to use a femoral distractor, placing a pin in the iliac crest above the fracture, and then in the femoral shaft below the fracture. And that really helps me. I can sort of dial in my vectors, and that helps me to maintain traction if that's what I need for the fracture reduction. Next slide. So variable number 1 is length. Number 2 is rotation, and rotation can be quite difficult. So for me, the way I find it helpful to help my rotational reduction is to put a point of fixation, usually a Kirschner wire above the fracture and a Kirschner wire below the fracture. And I use those as joysticks to try to sort of rotate those fracture fragments into a reduced position. So I'm getting length with my distractor. I'm dialing in my rotational reduction using those two points of fixation, proximal and distal to the fracture, to dial in my rotational reduction. The next reduction variable I need to think about is my varus valgus, and this is important and can be hard. There's no one way that sort of works for me, but certainly moving the leg into more or less abduction can help to control my coronal plane reduction, and also clamp application. So for example, if I have residual varus, a more cranial clamp application, shortening the cranial femoral neck can help to pull me out of varus. Or in contradistinction, if I have residual valgus, a clamp application along the calcar, along the caudal femoral neck can help to reduce my valgus angulation. So length with the femoral distractor if necessary, rotational reduction with joysticks on either side of the fracture, controlling varus valgus by moving the leg into AB or adduction, or clamp application based on the morphology of the fracture. And then the last one I want to talk about, because there was a lot of discussion, appropriately so, a lot of discussion in the panel in the previous cases about it, and that is, how do you control the sagittal plane? So how do you control that tendency for the femoral neck to roll off, for the femoral head to roll posteriorly off the femoral neck, for the anterior femoral neck, for there to be an apex anterior femoral neck deformity? And this is one example here. So I think that placing screws on either side of the fracture on the anterior femoral neck, and it allows you to sort of shorten the anterior neck. So usually what you have in that posterior roll-off is if you have posterior lateral comminution, for example, you sort of collapse in that comminution, you have a diastasis of the anterior femoral neck. So if you have something that allows you to shorten that anterior femoral neck, it really helps to bring that head out of the posterior roll-off. So this is a clamp application that I find very useful. Sometimes, so this is an example of using small fragment screws, 3-5 screws on either side of the fracture, going from anterior to posterior. And then a Young-Bluth clamp to sort of shorten that anterior femoral neck, and that's very effective. You can also use a clamp with 2 tines straightened on both the cranial and caudal side of that fracture, going from anterior to posterior, that can help you to correct that sagittal plane roll off. So those are sort of the four degrees of four directions of displacement that I find helpful to really get me a more anatomic reduction: length with a distractor, joysticks to help me more with my rotational reduction, leg position or clamp application for my coronal plane, and then something on that anterior femoral neck, something to shorten that anterior femoral neck to help me with that sagittal plane deformity. Next slide. So this is it. You know, I mean, it can get busy in there. You can see all those things. This is that patient. There's a lot going on there. But again, the magic is not in opening the capsule. The magic is in helping yourself and helping your patient to get a more anatomic reduction. Next slide. So just a quick word about mini fragment plates, because I think it comes up a lot. So in this example, you recall that there was that comminution along the calcar. So it keyed in nicely with the reduction, but one thing we thought we may be able to do to contain that calcar comminution, you can still see a little bit here, but one thing we felt we could do to contain that calcar comminution is to use mini fragment plates in sort of a mechanical buttress position along the medial femoral neck. I think that's great. It adds mechanical stability. It helps to neutralize that tendency for the fracture to shear. It creates a stable axilla for the neck to compress into. The difficulty is it's a very hard plate to get. You really have to flex, abduct, and externally rotate the hip to get access to that anatomic area. So what I often will do is place this plate prior to placing my medial buttress plate. So this is strictly adjunctive reductive plate. So this plate simply helps me with my reduction. It also can help me stabilize my femoral neck fracture in the sagittal plane. So this plate is placed on the inferior anterior calcar. I don't have to move the hip at all to get this plate on. I can put this plate on, and it can function a lot like my Young and Moose clamp was previously to help me with my sagittal plane. It also provides good provisional stability while I place my definitive implant, which in this example was a DHHS, so the helical blade, so as not to exert that rotational malreduction on the fracture that sometimes happens if you use a sliding hip screw. And then once I have those two implants in, once I have my anterior adjunctive reductive plate on, I have my DHHS in, or whatever I'm using, or DHS or screws, whatever I'm using to stabilize the fracture, then the last steps to take the distractor off, to flex that hip, to externally rotate that hip. And then that gives, I have a stable reduction, so I can do that without losing my provisional reduction. And that gives me access to that important calcar, so I can place my medial buttress plate to help with that. Next slide. Next slide. Yeah, so there's our final construct. We put that medial buttress plate on last to kind of hopefully create that stable axilla. This is the reduction the patient ended up with. Next slide. Okay, so that plate goes on last. This is him immediately post-operatively. He had his spine fixed the night before. This is us the next morning after fixing his femoral neck fracture. Next slide. At 6 months, he was healed. He was doing well. He did have some symptomatic heterotopic ossification in the distribution of his rectus muscle, and this will happen if you do Smith-Peterson approaches, unfortunately. But we excised that heterotopic ossification, and the patient went on to do quite well. Last slide. So here he is, and I've actually seen him since then. He's gone on to return to doing most of his activities. You can see he's a little bit shortened, but he's healed, and he maintained his varus valgus and his sagittal plane alignment very, very well. Now, one thing I want to say is I'm not using those mini fragment plates on all neck fractures. This was a special situation that you recall. You will have that neck comminution, and so those plates help me to contain that calcar in this example. I don't want people to get the idea that I use these mini fragment plates on all fractures, but if you're going to use them, this may be a good time to use them. So here, I don't know what else, if there's anything else. I think that's the end of that case.
Zahir. Thank Thank you, Dr. Eppel, for this very nice descriptive about the techniques of the open reduction.
Okay, guys. Thank you, Evan. Radwan, can you anything else here?
No, I will stop sharing and we will shift to session 2. By
Okay. Now we are out of time, so we need to shift to the next session.
Yes.
Okay.
Out of time, قوي يا جماعة.
But it is a good discussion. So.
Of course.
So.
No doubt.
Do we have a window for questions?
No.
No.
Okay, I will proceed.
No.
Okay,
Go ahead, please.
So next session will be about the fixation techniques. So we have either we do screws, as we have said, as we have seen, or sliding hip screw, and we'll see which is better and what's the evidence about these two methods of fixation. So let's go, Mustafa, please.
Okay, we will cover here the traditional methods of fixation, which are common here in Egypt, the cannulated screws and the sliding hip screws. We will continue the first case, which was presented by Dr. Radwan. This was a case of a young patient with vertical chair fracture, post-remedial comminution. This is the position that we ended up with.
Yes, into closed reduction.
Closed reduction in that position.
Okay. So I would like to ask the panel here, when we have this vertical shear fracture with our Powell's 3 fracture, which method of fixation would you prefer here? Screws or sliding hip screws? So, Ayman, what's your preference will be here?
I think this is vertical fracture.
Yes.
Higher shear forces and always had the comminution. Mostly we will found of comminution post-remedial. So I will think about more rigid fixation for this type of fracture. So I will go for sliding hip screw with anti-rotation screw. I think it will be better and it will do well with this type of fracture.
Okay. Anyone from the panel has a different opinion? So you all agree that sliding hip screw?
Because although the pinning is the most commonly used implant for neck femur, it cannot withstand the shearing or varus forces.
Okay.
Even if it is with a middle plate, Dr. Wael?
With a middle plate, I don't have any experience with middle.
Okay. I know, but if you have chance or we need to use this plate, this is ideal fracture to use this plate. Strong shear and it's a little bit low.
It's a very good option, Dr. Amr. It's a very good option also. The same idea. We have to withstand the shear forces.
I want to ask the panel, what about the configuration of these screws? Can it differ with the results? The other question, shall we use a fully threaded screw or not? Because I think all the participants have these questions in mind.
Yes.
I want to ask all the panel, including Dr. Eben, please.
So, okay, if you are going to choose the sliding hip screw, what are the tricks you are going to use to avoid the rotational instability that happens with sliding hip screws?
The tricks are directed against the rotational forces that is applied during application of the clockwise application of the leg screw.
Yeah.
So I always put a wire, thick wire, guide wire superior. I put more than one wire, two or more to make slight rotational stability during application of the leg screw. I think this is the only option available for me during application of the DHS.
Dr. Tara, do you have any tricks?
Well, in such case, I don't feel it's safe to do the procedure as a closed one without seeing the vertical inferior apex of the proximal fragment. So I always approach the calcar here and put a kind of clamp over the tip of the proximal fragment to prevent the rotatory effect or the spinning effect of the screw while I'm introducing it. So I don't feel safe at all to do it closed. I prefer to do it under complete vision while I'm putting this kind of clamp to prevent the spinning effect.
Like trochanteric fractures.
More or less, yeah.
Okay. Eben, would you do it differently or you?
No, I like that point. I think that, yeah, that if you are looking at it, and that is another, I think, reason that I get concerned about sliding hip screws is because, you know, I think I do a high percentage of open reductions on these young high energy ones. And if you look at it, you will see it spin. So I think you have to put as many provisional points of fixation as you can to prevent that spinning from happening. I agree that this fracture does have a nice spike along the calcar. So if you do choose to use that medial buttress plate, that is a very strong provisional point of fixation that will, you know, help to prevent that rotational moment, even more than additional pins placed in the head. So, you know, if you are going to use mini fragment plates in this case, that's nice from a mechanical standpoint to buttress that inferior calcar axilla, but also will give you some rotational stability.
Okay, but if someone is going to use the lag screw, let's go for the case here, Radwan here, Mustafa. Here they choose to use the spinning.
This is a sequence of the screws.
Yeah.
They decided to do the classical parallel configuration started by the inferior screw, partial threaded screw, in order to reduce this inferior calcar. After completion of reduction with partial threaded screws, the posterior superior screw, the anterior superior screw was replaced by a fully threaded screw.
Okay. So here, so if you are going to use a pinning cannulated screws, would you use this configuration or you are going to use another configuration? What, as Dr. Amr said, what about this positional screw or the fully threaded screw? Would you use it or not use it? So
we use the positional screw only if you have a posterior comminution to avoid to tilt the neck into retroversion. But we don't have a CT for this case to be sure if you have a posterior comminution or not.
That we have the CT. The out case that was the
first case presented by Radwan.
Can فيها
posterior comminution. Yes, there was.
Yes, I will use this configuration. The best configuration is the inverted triangle of the pinning.
Yeah, would you use 3 screws or 4 screws?
No, 3 screws. There is no difference between 3 and 4 screws.
I have to go back with the fully threaded screws. Eben, would you use the fully threaded screws? Does it have its role?
Yes, it does have its role. Yep, and you know, I think in this case in particular, if I was going to use a fully threaded one, I would consider placing it on the calcar. You know, one construct that I'll sometimes use is a fully threaded screw on the calcar, and then partially threaded screws up on the cranial neck, so that if there's any dynamism to that fracture, it'll tend to collapse, and you know, tend to collapse into valgus because the calcar strutted out fixed angle, and the cranial neck is partially threaded and maybe has some ability to collapse. But yeah, I think sometimes using those fully threaded screws is very helpful. But
we all know that the role of these screws or in fracture fixation here in the neck femur is that we need a compression, and that's why we usually allow the patient to come to walk. So we allow more compression. So the question is, how much compression do we need in fracture neck femur? Is it enough to have the compression done during the operation and that's it, or do we need to have more compression? And also that's the reason of the parallelism of the configuration, that we need to do compression. So
do you mean dynamic compression later on?
Yes, that's
continuous compression during weight bearing.
Yes,
I think we have a challenge here between 2 options, Doctor. 2 sides, Doctor.
Shortening.
We have to compress the fracture and we have to maintain the neck length.
Exactly.
So I think the sequence, this fully threaded screw will be the last one to apply when I achieve good compression, as long as I'm doing it open, so I can see the fracture with actual. So if I got the compression that appears for me to be anatomic reduction, I would, and I am afraid of collapse and neck shortening later on because there is a comminution. Lastly, I will put this fully threaded screws to maintain this neck length and to maintain this position.
Okay. So how much?
Dr. Zahar, very important point raised by Eppin about the sequence of the insertion of the screws. Not usually you start by the inferior at the calcar. If you have a little bit varus or you want to correct the varus, you should start by the cranial one to get the neck into a more valgus orientation. So it is not fixed arrangement of this fracture or the sequence of insertion of the screws.
Yeah.
Do you get the point?
ودكتور ظاهر بعد اذنك دكتور ظاهر لو ابراهيم الجنزوري معانا احب اسمع رايه. احنا عندنا we have many debates on this issue.
Eben, please can you answer
the sequence of the screws?
One thing that I have abandoned doing is using all fully threaded screws. So there's no doubt that we need to allow some dynamism to this. I mean, we need to generate intraoperative compression, but I think we've all seen that you have some fracture resorption, and we need to allow the neck to continue to compress on itself. So, you know, I will not use all fully threaded screws because I do not feel like right now fixing these fractures at length and getting them to heal reliably is something that we're able to do. I think we need to allow for a little bit of shortening to get them to heal. So if I'm going to use fully threaded screws, usually it's on the calcar, but my cranial screws are partially threaded. I've abandoned using all fully threaded screws because it doesn't let it slide, and I've seen non-union, at least in my cases.
Okay. Ibrahim, do you have any comment here?
I did not. I'm sure, unfortunately, I didn't hear the question properly. Can you please repeat the question?
How much compression do you need? And do we use the compression, the fully threaded screws or not? And when to use it?
Routinely, I don't use the fully threaded screw because I think I believe that this will not really prevent the compression because most of the bone here is cancellous. It's like an empty barrel. However, and I believe so much with the type of fixation that might matter actually, which is I believe that a fixed angle plate, rather it's a DHS or one of the newer plates, might help to maintain the reduction more. Regarding the compression, I think it's all related to the amount of reduction or proper reduction.
Yes. Okay.
Yes. Yes, Dr. Ibrahim. Then you are not with the screws and the configuration have been talking about a lot of time.
I'm with the screws. I'm not against the screws. Putting in mind that it should be placed in the proper direction, giving 3-point fixation. That is, as we see in this X-ray, it should be resting
the parallel configuration or the parallel configuration, Dr. Ibrahim, or no, you don't agree with the parallel configuration?
I'm not against the parallel configuration. However, I don't think it is the configuration that really matters. It's rather the placement of the screws with the concept of 3-point fixation, that is lateral cortex, inferior calcar, and the head, with the inferior screws, and the same with the posterior screw to give 3-point fixation to prevent varus and retroversion. The configuration, really, I don't believe it will differ or give a great difference. I think it is the methodology of fixation that might matter.
في دكتور خالد هنا wants to comment. Dr. Khaled.
Hello everyone. Hello everyone. I think here you have to deal with a lot of things. Firstly, the fracture line, the screws with the fracture line has a problem that makes the valgus induction above you see after reduction. Second thing, it's vertical. Yeah, the sliding heavy screw is superior to it, but it has been changed because of the direction, the fracture line to the screw. Another thing, it is preferable to have the inferior posterior one first. But even if you change it to positional screw, fully threaded, I think you have to make the inferior posterior one firstly positional, then to change all of them, not to change just the superior one.
Okay.
Thank you.
Okay. Thank you, Dr. Khaled. Any comment of what has been sent from the panelists? The panelists, do you have any comment? The configuration, the sequence of screws? Okay. So let's go on, please, Dr. Mustafa. We have some reference about it and some evidence about this question later on. We can show it to you. Dr. Mustafa.
Second case is nearly the same, garden displaced by 3 or 4 with posteromedial comminution. The preoperative X-rays will not allow us to identify which bowel classification posteriorly evident in the CT. Okay. The surgeon elected to do a fixed angle device, sliding hip screw with an anti-rotation on a traction taper after closed reduction. Okay, Dr. Zahir?
Okay, so any comment here? Would you agree about this fixation, or you are going to do it differently?
fully threaded screws using with the dynamic hip screw may affect the compression properties of the DHS.
Okay, but here we come to the same question. How much compression do you need? We are not using the hip screw here for
we have two types of compression. The static compression we get during the operation, and the dynamic compression post-operative.
Okay.
In pinning fixation, it is very difficult to allow the patient for early with pairing. I allow it only for touch for the first 6 weeks till some healing, except in valgus impacted, which can allow the patient for early with pairing as tolerated. In the DHS, which is commonly used in the pedal neck or transcervical, you allow for early with pairing, even full with pairing in such this case. But using this screw, fully threaded screw, may prevent the collapse at the fracture site or the impaction at the fracture site.
Okay, Eben, the same.
Against well.
Eben,
you are against well. أفهم بس صح. You are against well السكرو دوت.
Yes, I'm against.
Dr. Wael, you are against the screw دوت.
Yes.
Yes, you are against.
Okay. Eben, Eben, would you agree upon what Wael said? Would you use the fully threaded screws here with the DHS?
No, I don't think that I would. I think, again, if I'm using fully threaded screws, they're usually on the calcar because, if I'm going to make something fixed angle, I want it to be the calcar so I don't collapse into varus. Usually I'm almost always using partially threaded screws if that's what I'm going to decide, if I'm fixing with screws on the cranial neck. So, I don't have a lot of problems with this construct. I think that maybe I would have used an alternative means of stabilization like a DHHS or other implant. But if I was going to do this construct, I would have done a partially threaded screw on that cranial neck. Because again, I think, unfortunately, we need to allow these to dynamically compress a little bit to get them to heal. Dean Lort showed us that if even with good reductions and good initial compression, if you fix them out to length and don't let them slide, you're really risking non-union.
Okay, but would you prefer the leg screw or sliding hip screw or the helical screws?
My preference. So now I'm using a different implant, which I realize may not be available in your region. But I before that I evolved to using a DHHS. So it's much like the sliding hip screw, except with the helical blade. So it tends not to exert that rotational moment on the head and neck segment as I'm during insertion. So, if I didn't have the new implant, the FNS, which is what I'm using now, I would probably do a DHHS for this with a partially threaded cannulated screw in the cranial neck.
Yeah, but the problem with the helical screw is for its insertion you need to hammer it. So to hammer it, you can make more distraction.
That's a very good point. Yes, you have to control for distraction. So with the SHS, the sliding hip screw, will rotate. The DHHS will tend to distract the fracture. In my experience, the distraction moment is not as strong as the rotational moment. So it's easier for me to control or prevent it from diastasing than it is prevented from rotating. That's at least been my experience.
Okay.
Another point, Dr. Zahir, when using in the first case, we use not fully threaded in to avoid the posterior comminution and avoid retroversion. This is in case of pinning, which is not tolerable to the shearing force. But in using the DHS, which is a mechanically more stable in fixed angled plates, you don't fear of retroversion like pinning fixation. So you don't need to use the fully threaded screw.
Okay, but to make a comment here, because so not when you are using the pinning for the pinning, the fully threaded, it should be at the calcar level, not superior.
I have a comment, Dr. Sayer.
Yeah.
I think in this case we are facing the problem that we mentioned before. The difficulty in controlling the rotation of the femoral head during an insertion of the leg. So we have a problem in the reduction from the start. I don't think that this screw has any role in this fixation, because as Dr. White said, we put a sliding hip screw, so we will rely on the stability of this implant, the power of the stability of this implant. We don't need this additional screw. And if I want to add in fixation, I will put a short threaded, partial threaded screw to allow compression. So I think this case, so there was a problem in the reduction during application of the screw, and the position was some sort of, there is a rotation and distraction, which is maintained by this fully threaded screw.
Okay, so let's shift on, Mustafa.
Okay, but we will pass by some points about the fixation in both these issues, cannulated screws and sliding hip screws. First, we will emphasize the importance of spreading the screws while insertion in the femoral neck. As said earlier, the femoral neck is like a barrel with the main cortex at the edges. Try to put the screws as far and as near to the cortex as much as possible. In this study, the internal fixation was done by 2 screws. If the 2 screws are within 3 millimeters to the cortical bone, the fixation and union rates are higher than 1 screw or none of the 2 screws. Keep the screws apart as far as possible near the cortex by at least 3 millimeters. Do we have to do a 4th screw? There is a biomechanical study which emphasizes the importance of this 4th screw, especially in the initial stage of fixation. But on cyclic loading, there is no benefit in comparison with the 3 screws configuration. No clinical studies to confirm these findings. Whether to use fully threaded screws or not, the idea behind fully threaded screw is to avoid short neck, avoid the sliding and the dynamic compression that happened after reaching the initial compression and initial reduction. There are a lot of case series that involved using fully threaded screws in both the cannulated screw system and the fixed angle helical blade or DHS. The results are encouraging. The results are not bad. They are within the average of the traditional DHS sliding hip screws and the cannulated screws. Whether to use a Powell screw, which is situated perpendicular to the vertical fracture line in order to add resistance to the shear forces, add to non-parallel configuration to decrease the shortening in the length, and apply compression by lag mechanism along the vertical fracture line. These biomechanical studies showed that this configuration can be as biomechanically strong as a DHS sliding hip screw configuration. There is a trend in that the sliding hip screw is biomechanically gives us a biomechanical advantage over the cannulated screw. This is proven in almost all biomechanical studies. The fixed angle advantage, the large profile, gives marked biomechanical superiority of the sliding hip screw to the cannulated screws. As we go away from the neck in the basicervical and in particularly the vertical chair fractures, this biomechanical superiority is more evident. In some studies, in subcapital fractures, the cannulated screws can perform in a biomechanical manner near that of the sliding hip screws. But in almost all studies, the sliding hip screw is superior biomechanically to the cannulated screws. The problem is not with the biomechanical studies, the problem is with the clinical studies. There are a lot of conflicting evidence regarding this issue, whether to use this cannulated screw system or the sliding hip screw system. Two of the large studies that are done in the young population, the study in 2008 by Lepros, they found that non-union was higher in the cannulated screw system in comparison with the sliding hip screw, but this difference fixed angle, including DHS, DCS, and cephalomedullary nails. Another study which compared the Powell configuration clinically with the fixed angle device, sliding hip screw, and helical blade, they found statistical significant failure more in the cannulated screw Powell configuration group in comparison with the fixed angle group. This study was done in 2016. The previous two studies are on young patients with high energy injury, which we are talking about. In order to get a larger study, they involve mostly, like we all know, more common neck fractures are in the elder populations. So the larger studies will involve more old patients and more low energy injuries. The largest study, the FAITH trial study done in 2017 involving more than 1,000 patients, found that there is no difference in reoperation between sliding hip screw and cannulated screws. The AVN was higher slightly in the sliding hip screw. In analysis of subgroups, the sliding hip screws was found to be more stable, less reoperation in displaced fractures and in busy cervical fracture. Another systematic review collecting a lot of studies involving many implants from older implants, not only comparison between the sliding hip screws and the cannulated screws, found no superiority of any implant and found that sliding hip screws may actually reduce the risk of AVN. In a systematic review comparing the sliding hip screws with cannulated screws, fewer complications and faster union time were found with the sliding hip screw. Another one in 2019, 10 randomized control studies involving more than 1,900 patients comparing sliding hip screw with the cannulated screws found no significant difference as regard operation, union time, complications. What we can conclude from this is that there may be some advantage of sliding hip screw. This is not clinically evident, although it is far biomechanically evident. There is some advantage of the sliding hip screw. And this conflict in the clinical studies is also affecting our decisions. In a survey done in North America, most of the surgeons will use cannulated screws with undisplaced fractures. Half will use cannulated screw and the other half will use sliding hip screws for displaced fractures, and particularly for vertical chair fractures, the sliding hip screw will be the most commonly used fixation method. When they were asked, most of the surgeons referred to the biomechanical superiority of the sliding hip screw or the implant as their main choice to try this implant in such fractures. And whether they would change their preferred technique based on biomechanical studies alone, they indicated that they will need some form of clinical improvement and the clinical difference between the cannulated screws and the sliding hip screw groups by 10% at least. As we are talking about traditional fixation implants, we are not talking about novel techniques and new advanced technology. One of the traditional implants is to use an augmented plate as previously described by Dr. Carroll. Biomechanically, it will increase both the cannulated screw system and sliding hip screw system. It is very new construct with very few clinical trials. One of the latest clinical trials shown that the union is up to 89% of the cases, no femoral neck shortening, the concerns for the excessive dissection and the fear for adding injury to the femoral head and increasing the percentage of AVN was not present in this study. It was safe to do the medial buttress plate. Augmenting the traditional cannulated screws and sliding hip screws with the medial buttress plate could be an ideal construct, providing intraoperative compression, length stability, and in case of DHS or sliding hip screw, angular stability. Is number one priority. No implant can compensate for poor reduction. Still, cannulated screws are working for most of the femoral neck fractures. Sliding hip screws may add some benefit. This benefit is not well proven in clinical studies. Augmentation with medial plate may improve both cannulated screws and sliding hip screws results. Thank you.
Thank you, Mustafa, for these messages, and I think that's why we have said that this is the unsolved problem, the unsolved fracture till now. We don't have a full solution of that. Now we want to show you the latest or the Targum plate or the latest plates. I know it is not here in Egypt; it's very expensive, but it's very beneficial to show it to you and to have the latest advances. So it will be presented by Abel. Abel, can we go a little bit fast here?
Yes,
just
sure.
Yeah, because we are short of time.
Yep. So 20-year-old fall from skateboard. You see displaced fracture like we've been talking about, intercapsular, very vertical. Next slide. So CT scan, helpful to show the amount of displacement. Next slide. You can see the three-dimensional reconstruction here. It demonstrates that it's displaced, that typical posterior roll-off, but there's really an opportunity to squeeze this together and make this one nice if you open it and look at it, which is what we did. Next slide. So this is, we've done an open reduction and instead of using the screws on either side of the fracture here, we've simply used a clamp with two straightened tines to compress that anterior neck to correct that significant posterior roll-off that we saw on the three-dimensional CT. And the big difference with the implant I'm going to show you is that it's very protective of a provisional reduction. So we've all acknowledged that sliding hip screws and the DHHS are hard on a provisional reduction. Sliding hip screws will spin it off. The DHHS will tend to distract it. And I think my opinion is that that's why we haven't seen a big clinical difference between cannulated screws and sliding hip screws for femoral neck fractures, because clearly sliding hip screws are much stronger mechanically. So they should perform much better in the clinical arena, but they do not. And I think that's because the typical sliding hip screws or typical fixed angle implants really are hard on a reduction. So this new implant is not. Next slide. This implant is called the FNS, or the femoral neck system, recently released by Diffuse Synthes. Next slide. It goes in much like a classic DHS. You can see we're trying to put our guide wire here in the center position. Next slide. And what you can notice here is that I only have one provisional point of fixation on this fracture. So simply that one clamp. But the implant, this fixed angle implant that's very strong mechanically, goes in without messing up the provisional reduction. So that's the beauty of it. It goes in easily and it doesn't mess up your provisional reduction. So I simply have one clamp holding this fracture, but that implant's going in without any problems. Next slide. It's like a barrel, or it's like a blade that goes in first and has an articulated derotation screw that is a part of that of the blade. So it offers both rotational control because those two screws are articulated, so it offers anti-rotation moment. It's fixed angle, so it prevents varus. Fixed angle, so it prevents posterior roll-off, and it allows for some collapse. Next slide. So this is what it looked like immediately post-operatively. Next slide. This is is him postoperatively. I think we restored good anatomy compared to the other side. Next slide. And then this is him at a year. He went on to heal and do quite well. He actually didn't even shorten all that much, but we had good success with this implant. So I know this is not available to you, but I think the concepts are important, and that is that this is a fixed angle implant that is really made for femoral neck fractures. All the fixed angle implants we use now are made for intertrochanteric fractures or paratrochanteric fractures, but this one's made for the neck, and it doesn't spin the neck or doesn't displace the neck when you insert it, but it offers very good mechanical stability.
Okay. Any question about this new technique?
Is it inserted through a reamer or like a sitting chisel?
Yeah, it's much like a DHS. There's a triple reamer that's very similar to a DHS. Yes.
Okay, and what about your ideal approach for this kind of implants? Is it still you do a dual approach, Smith-Peterson and another accessory approach?
Yeah, still the same approach, Smith-Peterson to get my reduction, and then direct lateral approach to place the implant. Now, I will say this implant, you can see it, the side plate is very short, so you can put it into a very minimally invasive lateral approach. So the approach needed for this is a little bit smaller. It's more like the approach you would do if you're going to use cannulated screws.
Do you feel, Eben, that you still need a medial plate if there is a severe Powell angle, or with this implant you will not need a medial plate?
That's a good question. I think that I've used fewer medial plates since using this implant because, again, it doesn't spin, so I don't need that medial plate to hold things still. And it's as strong as a DHS or DHHS from a mechanical standpoint. So I still use that medial plate on some occasions, but this may make that a little bit less than necessary, particularly from a reduction standpoint.
Yes.
Can I ask a question?
Yeah.
The angle between the side plate and the screw, the main screw, the angle is 130 or 150?
It's 130. It's 130. There's a little bit of, as far as insertion, I think even the technique guide says you have, 5 degrees sort of either way, but the plate and barrel are 130 degrees.
Okay.
Last question, please, Eben. If you are using medial plate, you just do external rotation through Smith-Peterson rotation zones, or you have to have a medial approach like Ludloff approach?
No, I've just simply, through my Smith-Peterson approach, flexed, externally rotated, and abducted them. But again, that's why, I do have to, it's usually my last step because that does put stress on my repair. So I need a good, stable fixation prior to doing that. So
yes,
if I'm going to put that place on, that's my last step. If you're going to do a direct medial approach, as you described, you probably could do it without moving the hip.
Yes, my dear.
Good point.
Thank you.
Okay, I think we should stop here because it has been now more than 2.5 hours, and we have another session about the special situation. But I think every one of us is tired, and even the attendee has started to walk away. So at the end, I have to maybe we can do it another time, another session. Because it's very important to have this session about the special situation, so we can have it for another meeting. So at the end, I have to thank everyone here, or the panelists. I have to thank Eben for spending that much time with us. He's walking ahead. He's walking around the hospital all the time. We thank you so much for that, and I have to thank Dr. Tarek Sami because I know he sleep very early than that. So thank you, Dr. Tarek, Dr. Ayman.
Well, it was very exciting for me. Yeah.
Thank you, Dr. Ayman, Mustafa, and Radwan. A very nice presentation, and thank you for the audience and the questions. And lastly, Dr. Amr, that was amazing, and you have stayed with us for the whole night.
Thanks, thanks, Dr. Zahar, for this magnificent moderation. I think you are a perfect moderator, and we made this night fruitful for all of us. I think we have solved a lot of debates about this wicked fracture. And I'm very grateful to the speakers, Radwan and Abd, and very thankful for our panel. And again, very, very thankful and very honored by Eben Carroll to be with us. And I hope he will be with us in further webinars later on. And I'm very thankful for him. And I have to remind our participants, which I'm also thankful for him, that they استحملونا all this time, that this next week we'll have a very exciting webinar also like this in about tumors. Our tumor team, our magnificent tumor team, will have a good webinar. I think you will have seen Dr. Abdelaziz another time. This is a good chance.
This is bad luck.
And see you next week, and good night all. Thank you very much.